Good afternoon, everybody. We're going to get started. Welcome, everybody, to our monthly Grand Round series. And I'm part of the Lifespan IPC, along with Dr. Larry Friedman. And our IPC usually kicks off the new year, January. I'm a white woman with brown curly hair. I have like an army type of shirt on, and I have glasses, reading glasses, and I'm in my office today at the Mailman Center, and I'm the Director of Leadership Training Initiatives here at the Mailman Center. And we are so excited to welcome Dr. Laura Wolford, and she's going to be speaking about making sexual health accessible for people with communication disorders. And just a shout out, I forgot to mention the CME. If you're getting CMEs for this, it's going to be in the chat. So don't forget to check in and check out so you can get your CME credits. So Dr. Laura Wolford is a speech language pathologist, researcher, and trained sex educator. Her primary goal is to teach SLPs how to address sexual health with their clients. As a founder of the SPICE Institute, she teaches speech language pathologists and other healthcare educational professionals to address sex education head on. She provides workshops to teach how to bring up the topic of sex, how to address intimacy goals, and how to improve our own consent-based communication. So we're so excited to have you, Dr. Wolford, and welcome. The floor is yours.
Thank you so much. I'm very excited to be here. Hi, I'm Laura Wolford. My pronouns are she, her, hers. Visually, I am a cisgender, mixed race, Asian and white woman with long, dark hair and lighter skin. My shirt is black with white flowers. My hands are so cold right now. I don't know why. And I'm sitting in an office chair with a window behind me. It's lovely to be here. I should probably share my presentation so that you can see what I see. Okay, so the title of my presentation today is Making Sexual Health Accessible for People with Communication Disorders. This is an area that I'm very passionate about, as you can probably tell from that introduction. Frequently, our folks with communication disorders across the lifespan wind up being left out of a lot of sexual health discussions, and their communication disorders wind up being left out of the sexual health discussions that we have. And communication disorders can have a huge impact on sexual health, well-being, and safety. And so that's what we're going to be talking about today. Just some disclosures, because many organizations require them. I receive a salary from Midwestern University, Glendale in Arizona. I'm an assistant professor there. I am also the founder of the SPICE Institute, which stands for Speech Pathology, Intimacy, Communication, Education. Non-financially, I'm a member of the American Association of Sexuality Educators, Counselors, and Therapists, also known as AASECT. That may have bearing on the way that I think about sexual health and sexual well-being. I am a speech pathologist, so I come to this conversation with that lens. I know that not all of you are SLPs, so I've tried to be very inclusive of multiple viewpoints and backgrounds in this presentation. Please let me know if you have any questions or if there is something that I haven't thought of related to that. And I've never been to the Mailman Center, so the way that you handle client care. I know that there is a question and answer session at the end of this presentation, but if there are any clarifying comments or questions, please feel free to say them and bring them up during the presentation as well. Be very happy for that. Okay. Let's do stuff. These are some assumptions and biases that I personally come to from this work. I come with an assumption that the lessons that we learn as children affect us throughout life. That's something that I think we tend to be somewhat mindful of in general when we think about things like attachment styles, and we think about things like learning math. We carry that with us throughout our lifespan. But sometimes when we think about sexual health and sexual biases and the way that we perceive sexuality, a lot of folks forget that in the moment, that they think that you turn 18 or you turn marriage age or whatever it is, and that's when you start learning about sexual health. But really, the lessons we learn as children affect us throughout life. So the lessons that we learn about sexuality and how we should feel about our own bodies and the things that they do affects us throughout life. I come with the bias that people with intellectual, developmental, and communication disabilities deserve the access to information, body autonomy, and informed consent, just like anybody else. And the assumption that comprehensive sex education and sexual health are relevant to absolutely everyone. And in fact, they are human rights. And so that is the lens from which I look at this conversation. It's a health equity conversation. It's a health access conversation. It's a human rights conversation. I think it's important to note that I believe that sex education is relevant to anybody who has a body, and that's all of us. And because of that, as a sex educator, I have to approach conversations about sex with a very frank and open perspective, using vocabulary that is correct and addressing these topics with very direct language. I note that here before we have actually started the meat of the conversation, because a lot of us are very uncomfortable with that direct language. A lot of us are very uncomfortable, and that this may or may not describe you. But a lot of people are very uncomfortable talking about sex directly. And in fact, when I say the word sex, some of you may have kind of that internal flinching feeling. And if that's not you, that's also great. But I want you to be aware just up front that I will use words like sex or masturbation in this talk. And if that makes you feel uncomfortable, you are absolutely not alone. I ask that you sit with that if you can and try to unpack it a little bit. Most likely your colleagues and the families that you work with, the clients you work with, are going to have a very similar feeling, because that's the society that many of us live in. And if we're going to do this work, it's important that we meet people where they are. Some learner outcomes. I hope that at the end of this talk, you will be able to describe the link between communication disorders and the likelihood of sexual assault. I hope that you will be able to list 2 reasons why traditional sex education is very difficult to access for many people with communication disorders. And that you will be able to describe 2 ways that healthcare providers, including perhaps yourself, can help assist clients who have communication disorders in improving sexual health and consent skills. So that's what we're going to be addressing today. One of the first things, of course, that we then have to address is, how do communication disorders impact sexual health and safety? Certainly, being a member of the American Association of Sexuality Educators, Counselors, and Therapists, AASECT, when I introduce myself as an SLP in those settings, sometimes people go, okay. Why communication issues? Why would that impact sexual health? And then usually I repeat that back to them, because they're the ones who are often talking about how important interpersonal communication and consent is for sexual health. And I'm like, why would communication affect sexual health? And they go, touche. How do communication disorders impact sexual health and safety? Well, they do, because communication itself impacts sexual health and safety. It impacts our ability to have conversations about consent. Communication impacts our ability to have conversations about sexual health with our healthcare providers, with our partners, with family members. Communication impacts people's ability to access sexual self-esteem and self-efficacy. There was this really interesting study by Impit and Tolmit in 2006 that looked at when folks rate themselves as being better communicators about their own sexual health, they tend to have more self-esteem related to their sexual health, specifically young women, and they didn't indicate whether they were cisgender women. They were just folks who identified themselves as women. College-age women indicated that folks who were more comfortable talking about sex and who felt they were better sexual communicators tended to have much more sexual self-esteem. So they were less depressed about their sexual experiences. They were happier with their own choices. Communication impacts sexual satisfaction and also relationship satisfaction above and beyond sexual satisfaction. So the ability to communicate about sex really impacts the entire relationship, not just the sexual part of the relationship. People tend to feel closer to each other when they are better at communicating about sex. And so, of course, if a person has a communication disorder, that's going to impact all of those things. If it impacts communication, it's going to impact all the things that communication is related to. So communication disorders have been linked to things like reduced access to sex ed curriculum and increased risk of sexual abuse. And we will talk about these two things much more in depth in a moment. Difficulty finding romantic partners, reduced relationship satisfaction, especially in acquired communication disorders, and reduced sexual satisfaction. So communication disorders are very much linked to both relationship and sexual outcomes, as well as ability to receive education about relationship and sexual health outcomes. The information and access to sexual health education that folks receive as children impacts their overall sexual development across the lifespan. So remember when I was talking about those assumptions that what we learn as kids affect us as adults, and that sounded really obvious and silly to even say, this is where this matters, because it is true in the sexual health milieu as well. I do want to provide a content note or a content warning that this section of the presentation is going to directly address sexual abuse and assault. It's also going to address just some very sad gatekeeping stories. Like, this is not a happy discussion. I think it's worthwhile having the not happy discussion because it really pinpoints why this is so important, why not addressing sexual health is not it's not a neutral proposition, and why it's just an important conversation. These are the effects of not addressing sexual health with our clients with communication disorders. We know that language ability affects access to sexual health education, specifically in the United States. This study by Bernard Brack et al. In 2014 looked specifically at schools in the United States, public schools in the United States. It delved into a data set of over 9,000 youths with disabilities or disabled youths, depending on the language you prefer, in United States public schools. And they found that kids who had more severe intellectual disabilities were less likely to receive sex education, which is kind of interesting. If you look at the graphic on the right, you'll find that folks who don't have an intellectual disability, only roughly 50% of kids in United States public schools receive sex ed. Overall, no intellectual disability. Many states do not have a requirement for sex education, and many states above and beyond that do not have a requirement for comprehensive sex education. And there are no states that require that comprehensive sex education to include positive sex ed outcomes, like pleasure or positive experience of sex ed. So even those that require sex education usually don't have much discussion of things that are outside of the idea of STDs or sexually transmitted infections. So about half of our public school kids are receiving sex education. half of the kids who do not have an intellectual disability. In the graphic, it says that 44.1% of those with mild intellectual disability received access to sex education curriculum. So very similar to the percentage of kids without intellectual disability. That's not a huge difference, 47 versus 44%. Those with more moderate to profound intellectual disability, only about 16% received any access to sex education curriculum. And when they looked at what were the predictive variables of whether or not kids with intellectual disability, mild or moderate to profound, what were the predictive variables of whether or not they would have access to sex ed? Expressive communication ability. It was the only predictive variable for receiving sex ed, regardless of the level of intellectual disability. So when I'm thinking about school-age children and whether or not they're going to receive access to sex ed curriculum, the big question is, what is their expressive communication like? What is their expressive language like, their speech like? Because I know that that's going to be very important in whether or not teachers and other school professionals believe that they're going to benefit from sex ed and whether or not they're then going to be included. But even if they are included, even if they are technically in the room where the sex ed is occurring, sex ed materials are often very difficult to parse and they're not direct. I want to draw your attention to the 3 graphics that are on the bottom of the slide, and for inclusivity purposes, I'm going to describe them. The one at the left is a bird and a bee kind of cuddling up with a little heart on top. The one in the middle are 2 children, one of whom has longer hair and is wearing a dress, and one of whom has shorter hair and is wearing shorts and a t-shirt. They both have shields up, and like literal shields, like sword fighting shields. And they look like they're fighting off attackers. And then the one on the right are a person with long blonde hair and a person with short hair and a baseball cap. And they look maybe like teens. And they're looking at each other with kind of giddy excitement, and they have flush to their face and they're smiling, and there's little butterflies between them. Each one of these graphics was cribbed directly from sex education materials directed at folks with intellectual disabilities. And each one of them, if you think, oh, she stole these from sex ed materials, what then does that mean? You can probably, if you've had access to common metaphoric sexual discussions in the United States, you probably have an idea of what this stuff is. On the left, we've got the birds and the bees, which, what is that even? I don't know that I could directly tell you, but apparently they all reproduce. And so something related to sexual health, something. I, looking at that, go, oh, this is going to be a discussion about sexual health if I see a bird and a bee cuddling up with a heart over them. How direct is that? How much of a basis of understanding do I have to understand what in the world this graphic is trying to tell me? Quite a bit. In the middle, I see this, what I parse as a girl and a boy with these shields up, and I know that this is related to sexual health. I'm thinking, okay, this is maybe a sexual health, maybe a sexual assault related, like how do we defend against sexual assault, or how do we defend against unwanted sexual communication? This is going to be a discussion that is very much related to little kids and how to say no. And then on the right, the couple looking at each other, looking kind of flustered with the butterflies. We're thinking butterflies in the stomach, like flirting or feeling a new romantic connection. And that's what these visuals are designed to bring across, but they're so shrouded in metaphor. It's layers upon layers of, like, you don't literally have butterflies in your stomach when you're flirting with someone. I still have no idea what the birds and the bees truly are. These shields up, they're metaphorical shields related to unwanted sexual discussions, or it's layer upon layer of metaphor. And that's what kids who are engaging in sex ed are experiencing. There have been studies of what are we teaching kids? And they find that even curricula that are geared to folks with disabilities tend to rely on very complex language, metaphor, confusing visuals, such as, yes, there's a comment in the chat, none of these provide an accurate description to sexual education. Absolutely. None of these are what actually happens in sexual communication, sexual experiences, romantic experiences. None of them. I have yet to go on a date and put up a literal shield. It's not something that happens. So curricula, even for folks with disabilities, frequently has a lot of complex language, metaphor, confusing visuals. Sex education programs that are geared towards folks with learning disabilities don't systematically allow for adjustment related to communication needs. So gearing up and gearing down, communication complexity, language complexity. There's very little discussion of that. And if you think about, well, what would the visuals look like if we were trying to be more literal about things? You immediately know why perhaps we're addressing metaphor, right? Like more literal visuals would have folks kissing, would have folks with naked bodies related to sexual health. And a lot of individuals are going to be very uncomfortable with those more literal visuals. And so that's why sex ed is often very difficult to access for folks with communication disorders, even if they are technically in the room, which frequently they are not. Comment says, so if you're autistic or a person with autism, excuse me, I need to read this directly. So if you're autistic or a person on the autism spectrum, like me, we may not get the metaphors and miss the messaging. Absolutely. Or if you're having a difficult time just following the conversation and following the verbal output, and you're relying on the visuals, those visuals may not have anything to do with the thing that is being talked about. Yeah. And why does this happen? Why are kids who have intellectual disabilities, who have communication disorders, why are they so frequently excluded from sex ed? Typically because it's just not seen as appropriate for kids with intellectual or developmental disabilities. Often because kids with learning disabilities are seen as eternal children, according to McCarthy in 1999. So either they're seen as too pure for this discussion, or if they show any sort of vague inklings of sexuality, awareness of their own bodies, puberty, they're perceived as perverted or immoral, which those are two very different ends of the sexual health spectrum, and neither of them is, hey, here's a person, right? Frequently, there was a study by Garbutt in 2012, and we'll talk about that even more in a moment, but they were looking at when do folks with learning difficulties or intellectual disabilities, when are they seen, when do we even address sexual health of these individuals? And often only when a quote unquote problem arises. And if you want to be very sad, I would highly recommend reading this study. Garbutt goes into a lot of heartbreaking detail about what these problems are and directly discusses some of their clients. Folks, they discuss things like people believing they're sick or dying because they start to menstruate and nobody has brought up menstruation with them before. The inability to communicate about changes that happen during puberty, emotional breakdowns and emotional turmoil that happen because something is changing in my body and I don't understand it. Aggression and sexual exploration and bodily exploration that adults deem as inappropriate for that growing child, and therefore then gets shut down entirely. I warned us that we were going to talk about sexual assault. This is where we talk about sexual assault. This and the next slide. That is a difficult conversation. I just like to allow for a moment, and this was the moment. There are very high rates of sexual assault in folks who have intellectual and developmental disabilities, this and physical disabilities. We believe that this is especially true with those folks who have communication disorders. Depending on the study that you look at, there are wildly different estimates of what percentage of individuals with developmental disabilities experience sexual abuse, but 25% to 83% has been estimated. And then it is estimated that folks with communication disorders may be easy targets for those who are abusers. This Farrar et al. Quote, I'll just read it. The best victim is one who cannot tell. So it seems likely that people with disabilities who have communication disabilities are at very high risk. While there have not been studies that are specifically related to all folks with communication disorders and their risk of sexual assault or abuse, it is believed that disabled folks with communication disorders are 2 to 6 times more likely to be victims of sexual or physical abuse. And when we look specifically at folks who use augmentative and alternative communication devices, or AAC devices, as their primary form of communication, 39% of AAC users have experienced some level of unwanted sexual touch. So when we're thinking about our clients who have communication disorders, we're thinking of a population that is at higher risk of sexual abuse and assault, and have a much lower chance of accessing the communication necessary and the information that would be helpful in reporting that sort of thing or trying to prevent it. Specifically, this study of adult AAC users and their experience across their lifespan, Collier et al. Talked to adult AAC users, and they did a lovely job of just talking to AAC users and asking them all sorts of things about their experiences across the lifespan, and really getting into their worlds and offering help, thank goodness. When they looked at AAC users, most of their participants reported no opportunity to discuss healthy sexuality, changes in puberty, or abuse across their lifespan. No one to talk to about these things. One participant said, I saw on TV that people can get AIDS from a blood transfusion. I had never heard this before. I got a blood transfusion in the past. I didn't know what to think. I was shocked, scared, and worried. I was using a picture symbol book to communicate, and it had no words about sex or AIDS in it. Then I got a voice output device, but it was not programmed with any words about sex or AIDS either. So here's a person who's freaking out, very anxious about the possibility that could they have gotten AIDS, and has absolutely no way to communicate about it. One female participant expressed degradation and humiliation when her attendant opened her sexuality vocabulary and referred to it as, quote, dirty pictures. How much access to sexual health conversation do you think she had after that? Another participant they quoted, when I was about 10 years old, I started to notice my body changing. New things like erections and wet dreams and other normal parts of puberty. It was never explained, so I felt embarrassed about it and tried to hide it. All boys probably feel that, but they would get to talk to somebody about it. I wish someone had explained it. One male participant in his 30s reported using a communication display to disclose an incident of sexual abuse to the police, who did not pursue the matter because they did not think he would make a credible witness in court. While AAC clinicians typically do not become involved in sexuality education, they often are the gatekeepers of communication tools and strategies that can be used within the context of sexual health education and communicating about sexuality, abuse, and dignity. If I am in a position where I am programming my client's AAC device, I hold their ability to talk about sexual health, assault, the dignity related to being autonomous over one's own body. I hold that in my own hands. And whether or not I choose to allow my client access, and those words are awful, right? I choose to allow my client access to this vocabulary, but it's that is literally what happens. Whether I choose to bring it up, whether I choose to allow my client access to this vocabulary has huge, far-reaching implications for their own safety, their own ability to communicate about their own bodies and needs, their own ability to communicate about what's happening to them. In addition to things like pleasure and interests. This is a hugely important topic, and frequently we're so uncomfortable talking about it that we just don't. We just don't. We being speech pathologists, we being healthcare providers, we just don't. So now that we're good and sad, what can we do about it? Well, we can try to improve access to sexual health, knowledge about sexuality, autonomy, consent vocabulary. One of the most important things that we can do as healthcare providers is be willing to have conversations about sexual health. Healthcare professionals are known for not bringing up sexual health. Even healthcare professionals that work in the sexual health milieu often do not bring up sexual health, like gynecologists I always wind up bringing this book up off the cuff, and so I should probably start including it in slides. There's a book called Sex in the Brain by Amy Baird, and Amy Baird is a neuropsychologist who studies sexuality after neurological disease or injury. And in her introduction to Sex in the Brain, the book, she says, I never bring up sexuality, but my clients sometimes do. And I just think, oh my gosh, if you're not bringing up sexual health, if you're not asking your clients, what hope do any of the rest of us have? This is your field. So you might be surprised at who is not bringing up sexual health in their sessions. Healthcare professionals don't tend to bring it up. Educational professionals don't tend to bring it up. Clients are also uncomfortable bringing it up. Of course they are, right? But we all know that consent and sexual development are very important topics. We're uncomfortable. Most parents, clients, patients, caregivers, even if something is wrong, even if they have a burning question, there is a very high likelihood that they will not choose to bring up that question, because anything related to sexual health, sexual development, there's a high level of embarrassment, taboo, shame, discomfort. So it really winds up being on us as healthcare providers to broach the subject. And that is very difficult because we are often very uncomfortable talking about these subjects. Yes, exactly. It needs to be included as part of self-advocacy training. That was a comment. Okay, so how do we address sexual health in a general healthcare visit, regardless of what your specialty is? Bring up the subject. Bring up the subject with the client and the caregiver as developmentally appropriate. So we might ask, have you started talking about puberty yet? What sorts of questions or conversations are you having around sexual development? Do you want to talk about that? I ask all my patients about sexual health. Is that something you would like to discuss? Even something as super generic as that, right? Like sexual health, what is that? It's an entire field. Even something that generic can open the door to, oh my gosh, actually, yes, I had this question that your patient or their family might be uncomfortable discussing. If you have a client in front of you who has a communication disorder, ask yourself, does this client have the vocabulary to discuss this topic with you? So if they are a user of augmentative or alternative communication device or pictorial communication device, is that even an option on their device? And if it's not, know that perhaps the reason they're not asking you, even when you open the door for it, is because they literally cannot. If your client has very limited communication, this may not be something that they've ever talked about before. So they may not know how, they may not have the relevant vocabulary, even if they are verbal communicators. And so we may need to really make it very specific what you are asking them about, depending on what is developmentally appropriate for them. Ask yourself, does this client have the opportunity to speak with you alone? This is very important specifically for addressing sexual health and sexual assault. We know that in general, folks who commit sexual assault, especially for kids, tend to be people that they know. It may be the caregiver that brought them to the appointment. But even if you're able to communicate with your client, with the caregiver outside of the room, know that it is a very, very, very dangerous thing for them to tell you, for them to disclose. Our kids who are reliant on their caregivers for things like feeding, bathing, dressing, anything, they probably don't want any sort of negative repercussions related to their caregivers. When you look at that Collier et al. Study, you see that folks are very afraid to disclose these events because what if nothing happens? Then they're just left alone with this caregiver who's now very angry with them and who has a lot of control over their lives. So know that it may take a while. We may have to prove ourselves that we are safe to be opened up to. And then we have to ask ourselves, what makes us safe? Or do we know that we're safe? What would happen if they were to say, yes, there is something that I need to report? But even if it's not reporting of abuse, even if it's just asking questions, a lot of folks are really embarrassed to ask questions about sexual health in front of a caregiver. Because of course they are, right? A lot of us are very uncomfortable talking about sexuality in general. And so this may reduce their embarrassment if we're able to get them alone. And then also anticipate what it is that they may have questions about. Again, just bringing up the topic. Because I'm a speech language pathologist, when I think of addressing sexual health and speech and language therapy specifically, I'm thinking about things like modeling and discussing consent. So we need to be very consent mindful. My patient is autonomous over their own body, and I need to treat them as such. Even if they have mobility concerns or have difficulty moving their arm and we need to help them move their arm, we need to ask them if it's okay. We need to ask them if it's okay if we move their stuff. Modeling that consent is something that they should expect is very impactful. A lot of folks, especially with mobility differences, they don't often have access to that. People do just move them around without their consent. Talking about consent with the caregivers, having sex positive communication with caregivers. So saying things like, hey, kids this age have questions about puberty and sexual development. Is that something that you would like to discuss? Knowing that that is an okay thing for us to be talking about. Helping kids access sex ed curriculum. So if I have access to the school environment, asking the sex ed teacher what they're learning, what they're addressing, and then figuring out if I can address that relevant vocabulary, that metaphoric language with my client more directly, because my client might have questions. We may be navigating awkward social waters, things like dating, online interaction. I have been learning more and more about Tinder and Hinge and other dating apps these days, because I know that I need to be aware of what they're like, what accessing those dating apps is like for a person. But talking about what is safe and unsafe communication online winds up being very important for our clients. What is expected or unexpected online? Things like programming appropriate vocabulary and augmentative and alternative communication devices, like anatomy, like sensation words, or even more explicit vocabulary. If other kids can say it, why can't they? Most kids don't want to say intercourse and copulation. You know, more explicit vocabulary, more colloquial vocabulary might be much more appropriate for these kids because that's what other people are saying. Netflix and chill, maybe a communication button, or maybe that's old. Maybe I'm old. Maybe that's so 2012. I don't know. And then approaching sexual behaviors with a sex positive approach. This is very important. What do we do when we see a behavior, when we hear communication that we perceive as sexual? You know, you have a client in front of you who is grouping their genitalia. You might perceive that as sexual. Is it sexual? I'm not sure. Maybe they have an itch. But a lot of times adults perceive that as a sexual thing, or we see them with nudity that is not expected in that social experience or social situation. How do we approach that? Do we just say, stop it? No, like that's not an appropriate place for us to touch. We don't do that. Or do we provide redirection and education that, yeah, people do touch their genitalia, but probably not in the cafeteria. And so talking about where is an appropriate place to touch your genitalia. Oh, that makes you feel good. Great. Where could you do that? That would be appropriate. And we don't do this here. Why? So having a more sex positive approach, because again, the lessons that we learn in childhood affect us in adulthood. So if the lesson that you're teaching the child is, ooh, you're gross, what likelihood is there that that child is going to then feel anything that isn't, ooh, I'm gross, when they have expressions of sexuality? That's what we've taught them. Okay. How can we improve access to what we call the hidden curriculum of sexual health? That hidden curriculum is the concept that we learn a lot of stuff from peers, from our social interactions, from the environment in which we are living, the communication that we hear. We learn a lot from other people in a way that isn't directly taught from us. And to kind of get an idea of how important this winds up being in sexual health, I want you to think to yourself, how did you learn how a partner was supposed to treat you? However you would describe a partner, a boyfriend, a girlfriend, a paramour, whatever. How are they supposed to treat you? How did you learn what your body was supposed to do during puberty? What was normal? And then how you should handle it. What we should hide or not hide from parents or other caregivers. What we should be embarrassed about related to puberty. How did you learn what acceptable behavior was in a teenage romantic relationship versus what was breakup worthy? What a date is supposed to be like, what a good date is, what a typical date is. How many partners, sexual or non-sexual, is too many partners or too few? Because certainly people are very embarrassed about like never having had a partner or never having had a sexual encounter. So what is the right number of sexual partners or romantic partners? How did you learn that? Who taught you? Did somebody sit you down and write, it was in a book? Probably not. How did you learn what sex was supposed to be like? What was typical sex? How you were supposed to feel about it? Whether you should be embarrassed or proud. There's some discussion of like where the concept of the hidden curriculum came from, but I like to reference Miles Troutman and Sheldon in 2004. This idea is that the hidden curriculum is informally or unintentionally taught. There are things like social norms, social values, expectations. What are cultural expectations? Certainly from culture to culture and community to community, family to family, you have different expectations for what sexual health should look like, what a relationship should look like, what is typical versus what is unhealthy. This includes things that are implicit learning or peer taught, either learning information directly from peers or near peers, or learning lessons from being told like, oh no, from being rebuffed, or watching how other students handle situations, how other kids learn things and handle situations. The stuff that we learn from peers during sexual development and about sexual development is very important for our understanding of what is quote unquote normal, what we should expect from a relationship or from a sexual encounter, what we should expect, how much access to consent and body autonomy we should expect. Our peers share scripts. We learn scripts from other folks about how to talk to relationship partners. We share scripts for how to say no to unwanted contact and what we should consider unwanted contact, how to advocate for our own interests. One of the things about the hidden curriculum is that it is hidden. It's not direct. And so we as professionals, our first job is to recognize its value and its importance so that we can see if we can help our clients better access it. Oh yeah, books, movies, TVs, friends, religion. Yeah, learning by experimenting and hiding everything growing up as a queer youth, same. Absolutely. I love all these comments. Thank you for your interaction. I'm sorry that I'm a little bit slow. How can we help kids access this hidden curriculum? And, oh, yes, okay, we have 4 minutes. Specifically related to sexual and relationship development. Well, first we have to acknowledge that it can be especially difficult for kids to access who have social communication differences, who have reduced access to vocabulary about relationships or anatomy. We often access hidden curriculum by having conversations that are two-way streets, not just watching other people do things, although that counts too. Often we have it in conversation. If my client doesn't have that vocabulary to do things like describe the wet dream that they had, it can be very difficult for them to initiate that conversation. For our clients who have difficulty following a conversation or understanding nuance and metaphor, it can be very difficult for them to access this hidden curriculum. So we can help them with those things. We can help them have access to the relevant vocabulary. Again, not just like the word fallopian tube, but access to how other kids are talking about sexual anatomy. Every middle schooler that I've worked with needs the word boner. Like that's just, they need that vocabulary. Can we help them navigate these social situations by discussing them directly? You know, I saw this conversation that you were having. Do you want to talk about it? And then, of course, helping them identify their resources related to sexual health and safety very explicitly, like who could you talk to? Who would you talk to? Talking very explicitly about body autonomy and what that looks like. And the fact that they may one day, maybe now, want to do things like allow people access to touching their bodies. Not just how to say no, but also how to say yes and how to know when you want to say no versus when you want to say yes. One of the sad things about peer learning is that kids who are frequently bullied may be taught inaccurate information by those bullies and believe them. This makes it even more important that kids with communication disorders get direct access to comprehensive sex education, but instead we know that they tend to be the ones that are left out. In the end, if you do nothing else, if you take nothing else from this presentation, I hope you take away this. We have to be willing to ask our clients directly about sexual development, bring it up. And then if and when they want to talk about it, we need to be ready to have that conversation, wherever it takes us. It sounds like a very small thing, but it's honestly a very huge step. Just acknowledging that our folks with communication disorders, our folks with intellectual and developmental disabilities, this is a relevant topic for them too. Just that acknowledgement can be a huge shift for your client and their family. And it can lead to a lot more very fruitful, interesting, and very affirming conversations. Okay. Here are a bunch of references. I also provided a PDF, so I assume that you have access to them. But I'm also told that this recording is being recorded. So hopefully you can check that out, I always have difficulty. It's just a slew of references.
Dr. Walford, thank you. This was awesome. Thank you so much. This was so informative. And I know we're gonna open it up for questions now. So raise your hand or put it something in the chat. So we'd love to hear your questions and or comments.
Hi, Dr.
Christina.
Wolford. This is Christina Pujol,
Hello.
fellow speech language pathologist. Busy
Yes,
here,
parenting.
multitasking.
Absolutely. Good for you.
So my question is, I have worked with young adults with communication disorders and intellectual disabilities, but how do you navigate like getting parental consent from them as well? And especially being Hispanic, that's like so taboo to discuss. So how do you navigate that conversation with parents? Like, how do you get buy-in from them?
That's a really great question. And it's a very common question. I'm glad that you asked it. And being from a Taiwanese background, like, we do not talk about these things, right? We do not talk about them at all. I think one of the easiest ways to get buy-in, or one of the most common ways to get buy-in, is often our folks who are middle school age and above are already having, there is some reason that this was on your radar, right? Whatever it was, either they're talking about things that you think, okay, we need to be talking about sexual health, or they're doing something, you see them flirting with somebody else, or you see them addressing their own anatomy in a way that makes you go, okay, this conversation is relevant right now. If that is the case, which it isn't 100% always the case, but frequently it's the case, bringing that specific thing to the parent's attention. Like, hey, I've noticed that Johnny is doing this, and this is what it's making me think of. This is whatever it is usually very normal. It's usually very normal. It's usually very expected. So reassuring the parent in that way, I noticed that Johnny is putting his hands down his pants during the session. This is very common. This is not something to be embarrassed about. We see this during puberty or sexual development. I'm wondering how you might like me to address this. What have you been doing at home so that I can try to support that? And often it's something that the parent has already noticed. They're embarrassed and terrified and really uncomfortable with having this discussion. They've not talked to anybody about it. And then, at least in my experience, they cry. They have such an emotional, cathartic response to somebody else noticing this and accepting their child in this way, that they become emotional. They have this oh my gosh, thankfully somebody wants to help me in this moment sort of experience. And then you can have a very direct conversation about cultural roles and the cultural expectations for this client, what they're doing outside of session that you may not know about. And then how, most things are communication. So how can we support that communication? How can we draw healthy boundaries that also aren't shaming?
Thank you, Dr. Wolford. This was terrific. I'm one of the pediatric faculty, and we always emphasize sexual history taking and sexual discussions with the medical providers. And a lot of times the patients and their families with communication disorders, intellectual challenges, kind of find it nice and flattering when we routinely ask questions that we indicate are for all patients, no matter what their ability or what their issues are. And we might have to vary our wording, of course, depending on the level of understanding. But families oftentimes are pleased that we're inclusive of their children, just as we would be of healthy children who don't have those communication disorders or intellectual disabilities. So I appreciate the fact that you gave permission to all of us to bring up the topic, not wait for a patient or a family to ask, but to take the lead and have the initiative to introduce the topic. So thank you.
Yes, I'm so glad that you're doing that. Thank you. almost silly to say, but just acknowledging that a person with a communication disorder is a whole person who is deserving of access to the gamut of human experience, and that includes sexual health, is something that folks with communication disorders don't always get. And so it's wonderful that you're doing that. I'm so glad. Can I do anything for anyone else?
You see in the chat, there are lots of thanks and wonderful
know.
presentation and all of those nice compliments.
Yeah, I so appreciate it. Oh, I'm glad that you learned things. There are so many resources out there for health providers, healthcare providers related to addressing sexual health. Sometimes they're very difficult to access on a medical institution's what are those things called? The things that block you from having spam and the filtration, which is very sad. But sometimes like I wind up having to look things up on my phone or go like make sure that I do it at home, because sometimes those websites get blocked, even though they're just educational. I do have a white website, but it's devoted mostly to speech pathologists. It's spiceinstitute.org, or no, there's no spiceinstitute.org. There's more access to resources there. And please, if you want to reach out, please do. I have connections and I'm kind of steeped in this world at this point. So I'm happy to connect you with other professionals who address whatever it is that you address, because it's maybe not speech pathology.
Dr. Walker, I have a quick question, wrapping up. I was wondering, since we are all from different disciplines here at the Mehlman Center, social work, psychology, medicine, speech pathology, audiology, education.
Yeah.
Have you seen a trend in pre-service training, when you're in graduate school, learning how to be a social worker, psychology, OT, PT? I'm just wondering if that's in a trend where I'm a social worker and I never got any training about sexuality and sexual health when I'm working with clients. And 2 days ago, I got to present to OT students at Tufts University about sexual health and disability, and which was so encouraging that, OT students are now going to be getting some knowledge about sexual health and disability. So do you think that's needed, a trend happening? We do that here at the Mehlman Center a little bit. So
I think it's, of course it's so needed, right?
Yeah.
And I have personally noticed that there does seem to be more of an awareness that sexual health exists across healthcare, the healthcare spectrum. I have not noticed that is a trend that is coming from our national organizations, at least in PT, OT, and SLP. Like, you don't see that as being a thing that they are pushing for in like accreditation standards and in graduate school. I haven't seen that in any of our organizations, but I have seen a groundswell kind of from the ground up, which is what a groundswell is. Sorry for the redundancy, but from professors themselves. And I do think that in our society at large, we're talking about sexual health more and more too. You see it shows on Netflix about it, right? And like, you just wouldn't have seen that necessarily 15 years ago. So more and more people are talking about it, which is lovely.
Makes me think about the show Love on the Spectrum that was on Netflix. I think that was like a good intro to like think about how we should be addressing, relationships, intimacy, dating, all that jazz.
Yeah, and that it's relevant to everyone.
Yes. Well, this is a fantastic, and we could go on and on and on. So we really, really appreciate your time, Dr. Rufford, and we may bring you back in the future because this is a hot topic and it's very informative.
Thank you for having me. This has been very fun. Thank you all.
Thank you again. Have a great day, everybody, and a weekend. Good weekend. Bye.